Coming to anatomy of uterus. So uterus is a muscular organ, fibromuscular organ, and it is divided into the vagina, cervix. So this is vagina, cervix, and then this is a vagina. This is ostium that is opening into the cervix. This is endocervical canal, and this is lining of thin endometrium. Muscular part is myometrium, fundus of uterus, and these are the fallopian tubes, ovaries. So coming to histology of cervix, cervix connects uterus to vagina, and cervix is divided into ectocervix and endocervix. External os, that is a junction of ectocervix and endocervix. Internal os is a junction between endocervix to the endometrium. So ectocervix, it is lined by stratified squamous epithelium, and endocervix has glands which are lined by tall columnar epithelium. So this is a histology image of ectocervix. You can see this is lined by stratified squamous epithelium. These are the superficial cells, intermediate cells, parabasal cells, and basal cells. These are the endocervical epithelium, endocervical glands, which are lined by tall columnar mucinous type of epithelium. So one important part is the transformation zone, that is conversion of stratified squamous epithelium to columnar epithelium. So this junction is important for us because this is a place where there is carcinoma. The carcinoma can develop here because of the change in the epithelial surface, that is from stratified epithelium to columnar epithelium. So this is a histology image. You can see this is a stratified squamous epithelium of ectocervix, which is getting transformed to the endocervix, that is tall columnar epithelium. So from stratified epithelium, there is transformation to columnar epithelium. This junction where the transformation occurring is called as transformation zone or squamous to columnar junction. So coming to tumors of cervix, the most common cancer of cervix is squamous cell carcinoma, and the etiology is HPV, that is human papilloma virus. And this carcinoma cervix is a best example for an early detection with the help of a test called as PAP test or Pepinicular test. So it is a screening test, but it is very helpful, and the carcinoma cervix can be prevented early or recognized early. So whenever the adults with sexual activity with HPV exposure, that is human papilloma virus exposure, at the transformation zone in the squamous differentiation, it can lead to squamous intraepithelial lesion by low-grade HPV or high-grade HPV variants. Low-grade HPV very rarely causes carcinomas. They can cause warts or any other lesion. High-grade HPVs are most common cause for carcinoma cervix. And when this transformation zone is differentiating into the endocervical, that is glandular differentiation, it can lead to glandular intraepithelial lesion, that is adenocarcinoma in situ. This is again, the etiology can be high-risk HPVs. So this HPVs along with other etiological factors like OCPs, high parity, and any immune status alteration can lead to invasive squamous cell carcinoma or invasive adenocarcinoma. But in carcinoma cervix, squamous cell carcinoma is the most common carcinoma. So the risk factors can be early age and first intercourse, multiple sexual partners, increased parity, presence of a cancer associated HPV, exposure to OCPs, and any genital infections. So role of HPV. HPV is a single most important cause for cervical lesions. So they are high risk and low risk variants. In low risk it is 6, 11, 42, 44 and so on. High risk variants are 16, 18, 31 and 33. These are the most common high risk HPV variants which causes squamous cell carcinomas. And HPV can be detected by specialized tests called as hybridization test technique. So coming to pathogenesis of HPV infection, the HPV infection can only infect the basal layer and the immature epithelium. It will replicate in the mature epithelium. So whenever there is breach of the basal layer, the HPV will infect and replicate in the mature squamous epithelium. So therefore, transformation zone is an easy target compared to other mature epithelium because this transformation zone is mostly composed of the immature epithelium. So normal RB gene prevents proliferation of the cells in the absence of any growth signals, and P53 gene stops proliferation with altered or defective DNA. So these two genes, that is RB gene and P53 gene, are important for any growth signal, excessive proliferation of the cells. So this HPV will infect these P53 and RB gene. So HPV produces two types of proteins, that is E6 and E7 protein. E6 protein will inhibit P53 gene and E7 protein will inhibit RB gene, and ultimately it causes inhibition of the CDK inhibitors, which are important for cell cycle regulation. So altogether they causes dysregulation of the cell cycle and formation of oncogenes. This results in uncontrolled proliferation of cells leading to tumor. So before going into carcinoma cervix, there is a precancerous lesion called a cervical intraepithelial neoplasia. This is preceded by a precancerous state. They can remain chronic for as long as 20 years without any clinical signs and symptoms. And when this abnormal cells are shed into the epithelium, it can be detected cytologically called as PAP test. So this is SIN is nothing but it's a type of dysplasia. So they have given terminology for this dysplasias. When it is mild, it is called as SIN 1. According to Bethesda, it is classified as low-grade squamous intraepithelial lesion. Moderate dysplasia is called as SIN2, and severe dysplasia or carcinoma in situ is called as SIN3. According to Bethesda, SIN2 and SIN3 are together called as high-grade squamous intraepithelial lesion or HEDSIL. So according to Bethesda, there is LSIL and HEDSIL. LSIL is SIN1, HEDSIL is SIN2 and 3. So this is an image. This is a normal cervical epithelium, mature epithelium. Here you can see the dysplasia is starting at the basal layer, which covers almost 1/3. It is then classified as SIN1. If it is proliferating above, or if the epithelium is covered for more than 2/3, it is called as SIN2 and 3. And when it breaches the basement membrane, it is called as invasive carcinoma. This is a histological picture. This is a normal stratified squamous epithelium, mature stratified squamous epithelium. SIN1 is dysplasia starting at the lower 1/3. SIN2 is upper 1/3, and SIN3 is total epithelium is replaced by the dysplastic cells. So coilocyte change, it is common in the cervical epithelium. This is because of the HPV effect. So coilocytes, these they have nuclear enlarged hyperchromasia, coarse chromatin, and there is variation in the nuclear size and shape with a cytoplasmic halos or perinuclear vacuoles. These all are because of the cytopathic effect of the HPV. So when dysplasia is confined to lower 1/3, it is called as LSIL. If it is confined to upper 2/3, it is HEDSIL. And ultimately the whole epithelium is replaced by the dysplastic cells. It is SIN dysplasia carcinoma in situ. So coming to carcinoma of cervix, squamous cell carcinoma is most common. Second most common is adenocarcinoma, and other variants are adenosquamous or any neuroendocrine carcinomas, which are very rare in case of cervix. So morphology, grossly, it can present either as a fungating exophytic growth or any ulcerating type, infiltrative type, or ultimately the patient presents with advanced lesions with directly spreading to the peritoneum, bladder, ureter, rectum and vagina, or any regional lymph nodes. Distant metastasis can occur to liver, lung, bone marrow and others. So coming to microscopy of squamous cell carcinoma, they are divided into two variants, that is keratinizing or well differentiated SCC or non-keratinizing or moderately differentiated SCC. So most common of squamous cell carcinoma is keratinizing type. They have nests and sheets of malignant squamous cells. 5% are adenocarcinomas. It shows proliferation of glandular epithelium, dysplastic glandular epithelium, and 5% are poorly differentiated, which are again small cell or undifferentiated, in which neuroendocrine is a cause. So this is a gross picture of carcinoma cervix. This is the hysterectomy specimen, and here you can see the cervix with fungating type or exophytic type of tumor. So this is a histology. You can see this is a normal squamous epithelium, which is becoming carcinomatous and breaching the basement membrane and going into the subepithelial stroma. So this is an invasive squamous cell carcinoma. These are the tumor cells, which is having pleomorphic increased NC ratio with the keratinization, and these are the atypical keratin pearls. These are again keratin pearls with dysplastic epithelium and lymphocytic infiltration. This is adenocarcinoma. You can see the glandular type of epithelium, dysplastic glandular type of epithelium breaching into the stroma. So this is an invasive adenocarcinoma. So morphology of invasive carcinomas, 25% adenocarcinomas, adenosquamous and undifferentiated carcinomas can be present. Adenocarcinoma, most commonly they arise from the endocervical glands, which are lined by tall columnar epithelium. Even adenocarcinomas are preceded by an intraepithelial glandular neoplasm. Adenosquamous, it is less favorable, which has components of both adenomas, glands and squamous epithelium, so hence it is called as adenosquamous carcinoma. And clear cell carcinoma is very rare, and it can be due to DS exposure in the vagina. Relation to the papilloma virus is uncertain. So coming to staging of invasive carcinoma, stage 0 is carcinoma in situ, that is it did not breach the basal epithelium, basement membrane, so it is carcinoma in situ, which is stage 0. Stage 1 is confined to the cervix. Stage 1 is again divided into 1A and 1B. 1A is preclinical carcinoma, that is diagnosed only on microscopy. 1A1 is stromal invasion with no with size not greater than 3 mm. 1A2 is depth of invasion is more than 3 and less than 5. And 1B is histologically invasive carcinoma confined to cervix and greater than 5 mm. Stage 2 is carcinoma extending beyond the cervix but not onto the pelvic wall. So it involves the vagina but not the lower 1/3. Stage 3 is extended onto the pelvic wall, and stage 4 is distant metastasis. So what is a clinical course? Cytological screening is important in the form of pap smear, histological diagnosis and removal of any precancerous lesions. Pap smear plays a very important role. So whenever any adolescent or first intercourse, you have to do a pap smear to know the abnormalities. And so if in case of invasive carcinomas, it can be surgically removed by radical hysterectomies and adjuvant radiation and chemotherapy. Lately, HPV vaccines are also available for prevention, and periodic pap tests should be done for any management based or diagnosis based. Colposcopic examination and confirmation by histology is the ultimate diagnostic test, and HPV screening should be done. We can also do IHC markers like P16 and INC4A for confirmation of the carcinoma cervix. So this is a pap smear. These are the normal superficial and intermediate squamous cells. Here you can see the HPV effect of molding. The squamous cells are showing the HPV effect, coilocytic change with perinuclear halos and molding of the nucleus. And this is dysplastic cells with increased NC ratio, hyperchromatic nucleus. So this is L cell and this is H cell. You can see the increased NC ratios and dysplastic epithelium here. So these all can be diagnosed on pap smears. It is a screening test which will be very helpful for the management also for carcinoma cervix. So this comes to an end for the carcinoma cervix. Thank you.